We work closely with state regulators and policymakers. When we hear about systemic problems, we speak up and we try to get change on a systemic level. There we go. We advise families on how to get insurance to pay for mental health services. We submit electronic bills to insurance and we follow up on payment, which is sometimes you'll submit the bill and you'll think I'm done and you're not. And it's a process to get paid. We get pre and ongoing authorizations from insurance, mainly for residential treatment, sometimes for things like behavior analysis for kids with autism. We write a lot of appeals. That's kind of our bread and butter. We file grievances first with the plan, and then often with the state of California and other state regulators, or we do external appeals as well. We offer our services on a sliding scale on an hourly rate based on family income. And when we see systemic problems, we speak up. We try to work with legislators to let them know what's going on in their areas. We try to get families to speak up to their constituent services programs within the legislative offices. And we try to, we get involved with legislation. We put out a quarterly newsletter so that we can update our readership on what's going on. And we also provide how-to information and seminars in the community, like this one, and at conferences. Okay, that's my son. He's almost 30, and he has an AA in early childhood education, and he works as a teacher's aide in a preschool, and he lives with a roommate in the community, and we're very proud of him. He's accomplished a lot. So mental health services, it's a benefit that we pay for in one form or another. And mental health conditions are medical conditions, and they impact at least 20%, if not more, of the population, more since COVID. Standards of medical necessity include reducing pain, alleviating disability, and improving functioning. And that's physical and mental. Mental health is one of 10 essential health benefits that that is required to be covered through our health insurance, and that was through the Affordable Care Act, which is a federal law. And additional protections, including parity mandates, should make it harder for plans to deny treatment. The reality isn't always that way, unfortunately. How long can, a lot of parents ask this question, my child with mental health issues stay on my commercial health insurance plan? And this, due to the Affordable Care Act, it's age 26 now. It used to be when they finished high school, if they weren't going to college, and if they went to college, it used to be when they finished college. But now everyone can stay on till 26. And if your loved one is disabled by their mental health condition, if they're not able to work or not able to work, like I think it's 22 hours a week, if they qualify for SSI, if they're financially dependent on you, they may be able to stay on your private employer-sponsored plan indefinitely as long as you stay on it. We were able to get our son on it. We reached out to the health benefits program at the employer, and they were able to fill out a form and send it in, and it was easily approved with a letter from my son's psychiatrist. So ask your HR person at work, and then if your child qualifies for Medi-Cal, and there are many paths to qualifying for Medi-Cal, they can still stay on your plan. Medi-Cal is always secondary to a primary insurance. And when you retire, if you're eligible for Medicare, they may be as well through your benefits. Okay. Whoops. Next slide. If you're in a mental health crisis and you're trying to get services, we encourage you to designate a loved one or a professional, if you can afford it, to advocate on your behalf. Often that falls to the parents. I guess with older adults, it sometimes is the sibling. But if you're trying to do it yourself, it's really hard. And health plans, they don't make it easy for people. So they often try to save money, and they may not be motivated to provide the level of care that you and your therapist believe that you need. And most health plans have forms on their website for members. It's like a member designation of an authorized representative form, or it might be called something else, but they have these forms, and you can fill it out and have and designate another person to speak on your behalf. And I encourage you to do it because dealing with insurance is really stressful. And when you're in crisis, it's kind of the last thing you need to be doing. Stay involved in the big picture decisions if you can, but leave those stressful phone calls where you're hitting your head against the wall to a loved one if you have somebody that you can get to do it, just because it's really stressful. So where can you learn about your plan? You can learn about it, like what it offers, in the plan manual. And for those that have, if you have a small employer, or if you get your benefits through the marketplace through Covered California, it's going to be called the Evidence or Certificate of Coverage. And it's usually about a 100-page manual. If you have that kind of insurance, you would go to the website, and you can usually download it from your website. And if you work for a really large company, or more than, like, say 200 to 1,000 employees, then it's probably going to be self-funded. And I'm going to let Thuy talk a lot more about that, because her department regulates that kind of insurance. It's called self-funded insurance. But the document that you'd want is called the Detailed Summary Plan Description. And you would get that by logging into your employer's website, or through asking your HR for a copy of the detailed plan manual. And that's also going to be a government, about a 100-page document. And most Medicaid and government plans, they publish those documents online. And if you look hard enough, you can usually find them. If you've been denied care, you want to look up and see what the rules are, because sometimes they deny for reasons that aren't listed in the plan manual, and they're not supposed to do that. It's not really a valid reason. So these manuals describe what the rules are. They describe, like, how much time you have to appeal, how to file claims, what's covered, what's not covered. It's useful when you're involved in a dispute, or even when you need to know how to ask for services from your plan. So in California, fully funded plans, these smaller group plans, these employer-based and smaller group plans, or these individual plans that you buy on the health exchange on Covered California, they're typically regulated by the Department of Managed Healthcare. They are, if you get the plan through your employer, both plans are subject to the Federal Mental Health Parity Act. I'm going to skip over that. But it matters if you have a California regulator, because sometimes they will get involved when you have a dispute if it violates a California law. And sometimes the health plan won't let you know that, but they will know that. And sometimes they'll get involved and help you. And so it's important to know who your regulator is. There's a small number of plans, about 4%, that are regulated through the California Department of Insurance. If you have Medi-Cal, it's typically regulated by the Department of Healthcare Services, and some laws are the same and some laws are different. You may be entitled to what's called a fair hearing after you've gone through the appeal process. So you'd go through to an administrative law judge. Next slide. I'm going to skip over this slide because Thuy's going to talk about it. I'll talk a little bit about the State California Parity Act, Senate Bill 855. Senator Scott Wiener, he's in San Francisco. He was the champion of that bill. It passed back in 2021. I believe it went into effect. And it updated the prior Parity Act that California had. It was an act that basically gave services to people with about 10 different diagnoses. This one, it's sort of the new improved mandate, and it covers all disorders in the DSM, so all mental health conditions. And it requires that health plans use medical necessity standards that are evidence-based and have been developed by professional organizations rather than by for-profit institutions or by the company themselves. So when they turn to a for-profit institution or when the company develops the guidelines for medical necessity themselves, often the process is a little bit tainted by their profit motive. And there was a recent California case. It was a federal case. It was called the Witt case. And in that case, that was the subject of the case. And that case has been moving around between the appeals court and the trial court. But the most recent ruling from the California Court of Appeals was that they get to send their cases back to the plan to be re-adjudicated under more objective healthcare standards. But this now the findings from that case has become part of California law. And so one of the things is that they must provide all medically necessary treatments, including intermediate levels of care, which includes residential treatment. They must treat the underlying conditions, not just the current crisis, the why now factors. So what happens, what the experts in that case testified to, was that when they treat people for what's going on, like immediate issues, the underlying factors don't go away and they still continue to need treatment. And so this law requires them to get to the bottom of what's going on and not just treat the crisis issues. They must err in making these determinations, whether or not something is medically necessary. They must err on the side of caution and safety in making these determinations. And if it's sort of on the border, they're supposed to mark it up because they found that undertreating can result in harm. Not treating with enough care can result in harm, but overtreating isn't necessarily harmful. And they need to treat not just that the standard is not that they need to continue to make progress. It's that they need to maintain what they have and prevent further deterioration in their condition. So I'm going to talk a little bit about what to do when you want a mental health treatment and where to start. So if you're in a managed care organization, we encourage you to make a good faith effort to try to explore what is available in the network. And we encourage you to do this even if you have a PPO plan and out-of-network benefits. And the reason for this is because it will pay a lot at a much higher rate. A lot of out-of-network care, they only pay like maybe 50% after they determine what is the usual rate. And so if you go into a psychologist and see a psychologist and they're charging $250 an hour, which isn't unusual, the health insurance plan might say, you know what, our usual and customary rate is $100 an hour, and we only have to pay 50% of that. And so that's like a Band-Aid. That's really partially treating. And here's something that's important to know. And another study, there's been at least two national studies that have explored that networks are much less adequate for mental health treatment than for medical treatment. And so there's a very good chance that if you need a psychiatrist right now, that your health plan may not have anybody available for several months. And that's unacceptable. California has rules about prompt treatment, and they're supposed to get you in for the first time within 10 days of your calling in to request it. And it's 2 days if you're in crisis. So when you're calling your insurance company, do not understate the problem. Be specific about what kind of provider you need and what the problem is, and that you need expertise in that area. Describes what's going on and what level of care that you're seeking or that has been recommended. So if you're trying to go to residential treatment, it's often gender specific. So if they only have a program that serves like men and you're a woman, that's not going to work. If they only treat adults and you're like 15, that's not going to work. If you have PTSD or if you have autism, say, a lot of these plans can't treat, they just aren't adept at treating autism, or they may not have expertise in treating trauma. And so you want to go to a facility that has expertise in your problem. And so it's important to describe that and try to get them to filter it out when they give you recommendations of places. They might refer you to a website, and if you know that something's only day treatment but not residential, then that's off the list. So you may have to weed through the list. If you can't find anyone that's appropriate on the list, call the plan back and ask them to help you find an appropriate provider. So the new California mandate requires the plan to help arrange services when their network is inadequate. So that's helpful to know. And if you're in a PPO, it's still a good idea to explore the network, because the plan will pay at a higher rate, and the therapist will sometimes they'll take responsibility for filing the claims, and they'll take the risk of not getting paid. And they may go to bat for you and know how to work with insurance. Next slide. Whenever you call your plan, you're going to write down who you spoke with, the date and time of the call, and you're going to request a reference number for the phone call. Because if you don't have a record of it, then it weakens the credibility of your case. So build a paper trail early on. Make an effort to get that list of providers, call down the list, mark up the list, and show the list to your doctor, or if there's nothing that works, show your list to your doctor or your support group or your consultant, other people that might know who's good or who has expertise in the problem that you're dealing with. If they don't call you back in 24 hours, that's a no. If they don't have space available, or if they only take teens and you're an adult, or if they only do eating disorders, that's a no. If you get no hits, call the plan back and tell them that their network is insufficient. If they won't help you find a provider or placement, go back to your support group and ask who's good. And then once you've found a provider, call the plan again and request either a network exception or a single case agreement. And a single case agreement, they work out an agreement with the provider, and they decide how much they're going to pay, and they do that all in advance. A network exception, it's very similar. Sometimes the providers have had bad experiences and they will not work with insurance, and that is not unusual, unfortunately. And if that case, you ask for a network exception and they're supposed to come up to the rate that the provider's asking, you're not supposed to have to bear the cost of the difference in what they pay and what the network pays. So California network adequacy standards require initial visit with mental health provider in 10 days and 2 days if it's urgent, and within 15 miles or 30-minute drive of your home for most counties. Some rural counties, it's a little further. And the DMHC, Department of Managed Healthcare, the state regulator, they have a lot of this information on their website about how to make the plan, come around and deal with what you need. So PPOs and open choice type plans are also obliged to provide an adequate network. Sometimes they'll try to tell you, oh, that's why you have out-of-network benefits. No, that's not why you have out-of-network benefits. You have out-of-network benefits so that you have a choice, but they have an obligation to provide a network of providers. And the facility or the provider may need to be willing to do pre-authorizations and check in on a regular basis with the plan to give them updates on how you're doing and then they make a decision as to whether or not, this is mainly for residential and some like partial hospital and IOP, they might need to be able to say, you know what, I think the care is no longer, you've made some progress and now you can function at a lower level of care. So that is something that you may need to do. And we can bridge that gap if you need us to, but we do charge for our services. But it is something that we can do if the provider won't do it. So pre-authorization is asking for permission. First, with managed care plans, you pretty much always have to do this. And for outpatient treatment, they often give you a number of sessions, and then somebody is supposed to call in and get more and give them a little bit of an update. For facilities, for mental health, residential, IOP, PHP, often they want to speak to the provider and check in or with a provider rep. Within a day or two of admission, and then sometimes on an ongoing basis. And so this information is mainly for providers. So I'm going to go to the next slide. And then this one is also, if you're submitting your own claims, make sure that the provider's name, address, phone number, national provider identifier number, NPI, and tax ID number is on the bill. And then your date of birth and the name and diagnoses of the patient is on the bill. And then they want to list each date of service and the procedure codes and the cost of each procedure. So if it's not complete, you want to ask your provider to redo the bill. And if you submit it yourself, you might need to submit it with a member claim form, or you might need to submit a receipt, and you might need to submit a receipt to show that you've paid out the claim in advance. The plan is supposed to process within 30 days, but they don't always. Okay, whoops. And then if any of you have Medi-Cal, what is available may vary by county. And sometimes it's treated in the county mental health system, and sometimes it's treated in the health plan itself. And legal aid has a contract to help with some of those appeals. There's basically two types of denials. If you're denied, carefully review the reason. There's medical necessity denials. They're supposed to tell you why it's not medically necessary. And then there's not a covered benefit. And that's a dispute about payment, or it could be that the benefit is excluded. And medical necessity can be denied at the start, or it can be denied later once they've approved a certain number of sessions or certain number of days. But they need to tell you, they need to provide that letter in writing and tell you why they're not covering it. And these are some of the common reasons we see for denial: not suicidal, homicidal, or actively hallucinating. This is kind of a narrow view, and it's often what is required for inpatient. They might say you're currently stable and don't need this level of care, or they might do the opposite and say that you're making progress and you don't need this care. Or they might say you're too impaired and you're not making enough progress. They could say that the care could have been provided at a lower level. They could say we don't meet our criteria. And often clients do meet the guidelines, but the health plans are motivated financially to deny. So you have a legal right for the written reason for denial. And you have a written reason, you have a written right to the guidelines that they used, and also the clinical anything in writing that they have on why they denied care. It's called the clinical file. If it's not paid appropriately, you can dispute that and request that they reprocess the claim, or you can ask and find out why they paid the way they did. Typically, your deductible is taken out first, and then they can pay a percentage of usual and customary rate. And then these are common things that we see for administrative denials for facilities. I'm kind of running low on time, and so I will make this slides available if you want them. I'll send them to either James or Dawnel, and you can get them if you want to. So here is something else. There is a law in California called Senate Bill 1324. It's from 2008. It's been around a while, and it forbids plans from rescinding authorization once they've authorized a service, and the provider delivers it. The plan may not rescind or modify the authorization for any reason. That is a very strong mandate. So if you've been authorized services, get the authorization number, get the tracking number from the phone call where they told you they were authorizing the services, request the authorization in writing. And this applies to Medi-Cal as well. So it's very useful to know that, because the plan won't tell you that, but the regulator will back you up on it. Okay, this is what needs to be included in a denial letter. So they must make documents used in the decision available to you upon request. So request those documents that were used in making the medical necessity decision. And they're supposed to instruct you on the next steps, including whether you have 1 level or 2 levels of appeal, and whether you have an external appeal. And nearly all programs now have the right to an external review, which is a really important thing. They must disclose the availability of who you can go to get help. And that's California Health Alliance for state-regulated plans in California. And they have contracts with a lot of the legal aid offices in California. And if the plan fails to adhere to the requirements, then it impedes the process, then they've exhausted the appeal and you can jump over to the next steps. Appeals. Some plans allow 1 level, some plans allow 2 levels, and some plans allow an optional 2nd level appeal. And that's another reason you want that plan manual. The plans might pressure you to apply by phone. Don't do it. Create a paper trail and write all the reasons down. Think carefully about why they're denying and why they shouldn't. And if you do get to external review, which most denials, if you follow it through, you'll have to do. And so then you have to put that one in writing. And when in our practice, we do a lot of those appeals and the external review requests. We also bring in the guidelines that they're now required to use, which is called CalLOCUS for children, LOCUS for adults, ASAM for substance abuse. And these are national standards that they're required to use, and they're less biased than the ones that have been developed by the health plans themselves or for-profit organizations. So this is a little bit about what to include in an appeal letter if you're writing your own. And again, I will give this to you. I will give the slides if you need them. If your appeal is denied, real justice often, unfortunately, does not happen till you get to external review or regulatory intervention or litigation. If you're denied for payment or administrative issues, in many states, the regulator will help you and intervene. In California, they will. If denied for medical necessity, external review is available. And you can also go to litigation, but most lawyers want you to have spent close to $100,000, which is hard to believe. A lot of them work on contingency, and it shouldn't have to be that way, but a lot about our healthcare system is broken. So this is what we have found. So external review is a process where it goes out to an agency that is unaffiliated with the health plan. And for mental health claims, it's usually reviewed by a psychiatrist. And they will look at the clinical files, and they will look at other documents to determine if services were or are medically necessary. If the plan is regulated in California, it will go to the California state regulator and they will send it out. And then they do publish their rates of overturn. In California, I believe they're saying that close to 65% are overturned, which is a very high rate of overturn. So it means that stay the course, and especially if you're denied for medical necessity, and if you feel that you were really denied unfairly, see it through to the end. The laws are in place for litigation, but and generally the health plans aren't following them. Class actions can promote lasting change through the whole industry. It sends a very loud and clear message to all the insurance companies. Many lawyers work on contingency, meaning that you don't have to lay out the money, that they only collect when they win. If they think you have a good chance of winning, or if there's enough money at stake, they may take your case. And sometimes, I hate to say it, it's the best option. It shouldn't be that way, but that is the way that it is. So that's my presentation, and I'm going to, I think I'm passing the baton directly to Thuy at the Department of Health.
Thank you so much, Karen. I know I will want those slides.
Okay, great.
And I think our peer support specialists, another NAMI employee,
and reach out when you're stumped on how to help someone, and also feel free to refer families to us.
Absolutely. And with this, I think we should commit a lot of this to memory, just because it's really important.
You won't remember it. It's too much to remember, but if you have the slides, it's a good place to start. Our website also has a lot of tools on it.
Phenomenal. Thuy, I know, because your slides are special, would you like us to stop recording and then start recording once you're done, or are you okay with us recording your presentation?
You're fine recording. Can you hear me okay?
Yes, now we can hear you fine.
Yeah, you're fine recording it. I just cannot share a copy of the presentation.
Okay, that makes sense. Okay, Dawnel, let's get Thuy's screen out.
Yes. Karen, can you stop sharing? And then Thuy, you should be able to share. And I have you spotlighted as well.
Okay. Let me get do I have to stop sharing?
I think I could do it for you.
And pull it back. This is not, it's blocking my view of it. Yeah. So I can't. There you go.
All right. Thuy, you should be able to share now. Thank you.
See my presentation?
Not yet, but it takes a minute.
Yeah. Not yet. But we will.
If you have multiple screens open, you might have to designate the screen that you're sharing on.
Yeah, there it is.
Yeah,
okay.
Yeah, there you go.
All right, thank you. All right.
So, good evening, everyone. My name is Thuy. I'm from the U.S. Department of Labor. Our agency is called Employee Benefit Security Administration. We are one of, I think, 19 different agencies in the U.S. Department of Labor. And our work is very specific to employer-sponsored benefit plans, such as a health plan, a mental health plan, or a pension plan. So today I'm going to talk about the Mental Health Parity Act. It's the law that requires that mental health benefits in your employer-sponsored plan be equal or in parity to your medical health plan. Okay, so first let me give you a little bit of background about our agency. We administer a federal law called ERISA, which began with employer responsibility and employee rights. And throughout the years, since 1974, more specific laws were added, like the COBRA law, the HIPAA law, and then ultimately the Mental Health Parity and Addiction Equity Act. We call it MAPIA for short, but that's the name of the law. It basically is applicable. So I'm sorry, let me back up. Our work is applicable to an employer-sponsored benefit plan in the private sector. So if you work for a public sector employer or a religious entity, the rule is not applicable. Although those plans may follow similar rules, but we don't have jurisdiction over those types of plans. And our law is a federal law, so it's applicable to all employer plans that are self-funded. Like Karen had mentioned earlier, There are different types of plans, self-funded plans and fully funded plans. So if you have a plan that is subject to the federal laws under the Department of Labor, it's self-funded, which means that generally the employer sets aside funds to pay claims. And so it's self-funded. And those plans are subject to the laws that we administer. So then it does not require an employer to have a mental health plan. So many employers now have a medical health plan and they have a pension plan. And in many cases, they have a mental health plan. And the law also further goes into whether or not the rule is applicable depending on the size of the employer. So what we look at for Parity is 6 different factors: deductible, copay, premium, pre-authorization, in-network, and out-of-network. Those are the factors that we use to compare whether or not the plan is in parity with a medical health plan. So those are the things that we're considering. If the employer has a medical health plan, it has to be in parity, and these are the factors that we look at. And these are very common things that you've heard about in your own medical plan, right? You've got a deductible, you've got a copay that you pay every time you go see your service provider, and you pay the monthly premium, and depending on what services you have, you may have a pre-authorization requirement. And then, of course, you have your plan contracts with certain providers, and they could be in-network or out-of-network. So those are the factors that we look at. So now, so the employer may sponsor a benefit plan. The union can also sponsor a benefit plan. And if it's a union plan, for example, and I'm not picking on this plan, but, UAW may have a plan. That's a union. Teamsters might have a plan. United, the telecommunication workers, they may have a mental health plan in addition to the medical health plan. And if they do, we know that they're larger than 51 employees, so we know that they're subject to the parity law. So there's several levels of consideration that we have to make to determine whether the plan is subject to the law. So the Mental Health Parity and Addiction Equity Act, the MAPEA law, essentially, like I just mentioned, it's subject, it has to be in parity with your medical health plan, and it's subject to employers that have 51 or more employees. So if you work for a small employer and that employer has less than 50 employees, they have a medical health plan and a mental health plan. And unfortunately, if there are problems with the mental health plan, it may not be required to follow these rules under the federal law. Okay, so those are things to consider when we talk to someone. We have to get all of this information in order to determine if we can even look to see if there's a violation of the plan. And when we review plans, we look at financial requirements and treatment limitations. So we internally refer to them as QTLs and NQTLs. So QTLs are financial requirements like your copay, deductible, coinsurance. So for example, if your medical health plan through your employer or union has a $20 copay for you to go see Dr. Jones when you feel sick, and if that same employer has a mental health plan, it cannot impose a more restrictive copay, such as $100 to go see Dr. Smith when you need to go see a mental health care provider. So that's what we look at. All of these different factors, that copay, deductible, coinsurance, pre-authorization, out-of-pocket maximum, we make sure that they're in parity. Now, the treatment limitations are also something that we review. Treatment limitations include, and this is not the exhaustive list, but it includes things like pre-authorization. So, for example, if your plan, your medical health plan, doesn't require that you get pre-authorization to go see the doctor when you're sick, it shouldn't require that you get an pre-authorization to go see a mental health provider. Okay. If it does, then it's not in parity. We actually have in our Los Angeles regional office, we have an initiative where anytime that we come across a question on a health plan, we take an additional step and we request the summary plan description and summary of benefits and coverage. And we review all of those health plans, no matter what the question began as, we review them all for parity, because there's no other way to figure out unless somebody complains. So we take an additional step to do the review. And like Karen mentioned before, there is a state law that are applicable to certain plans that are under the jurisdiction of the state. Those are called fully funded plans. And it sounds like there are many things that are parallel to the federal law, but federal law does not require that a mental health plan be provided. So if there is one, it has to be in parity, but only if the employer has 51 or more employees. Now, in our work, we're constantly talking to people who have problems accessing benefits. One of our regional offices, we have 10 regional offices, and one of our regional offices was able to help this woman who could not find an in-network inpatient facility for her daughter who needed treatment. So she had to take her to an out-of-network provider, and she had to pay out of her pocket $200,000. Yeah, I know. It's so ludicrous, and I cannot even imagine being in that situation. But because the plan did not have an in-network provider, our agency was able to get an exception for that woman, and the insurance carrier paid back the benefits in $200,000. You know what she had to do? She had to take out a second mortgage to pay for that benefit. And when they paid her back, she was able to pay back her second mortgage. So, I mean, that is one of our great success stories. But when we get involved, we review the plan very thoroughly to determine whether or not it's in compliance. And if it's not, then we correct the issue for the participants, So we look at all of these different factors like pre-authorization, the fail first policies. Like, they can't force you to try this first, see if it works, try that, see if it works. If there is a prescribed treatment for a certain ailment, then that's what you should receive under these benefit plans, because you pay for it, right? Through your employer, you enroll in these plans and you pay for these benefits, and you should get them. You shouldn't be tested in these types of benefit, like these types of procedures, like fail first. So we also have. Do you still see my presentation?
Mm-hmm. Yes.
So we similarly, our benefits advisors were able to help get benefits covered for another individual who had a teen who also went out of network to a facility out of network. But you know what? In that case, they approved the out of network exception. But then the insurance subsequently didn't honor their approval.
Yeah.
And they denied the claim for $92,000. So our agency intervened and investigated, and it resulted in the plan reversing the decision and paying the claim at the in-network level as it had promised. It had approved. So that is a couple of our the effect of our work. Now, we can help anyone across the country. We're a federal agency. And similar to what Karen was saying, mental health is medical health. It goes to your overall well-being. So we should broaden the treatment, the talking about mental health and getting treatment, so that we reduce the stigma in the mental health and get people treatment where it's needed. So let me go back to this. Now, we were talking about treatment limitations. Treatment limitations are called NQTL, non-quantitative treatment limits. And those are things that you should be on the lookout for, because those are the ways that the mental health plans are not in parity with the medical health plan. They restrict certain benefits that they normally don't restrict in your medical health plan. What you should do, like Karen mentioned, is to get a copy of your summary plan description, and then also the summary of benefits and coverage. The summary of benefits and coverage, the SBC, is a chart. It shows you in-network, out-of-network. It shows you what it costs to go to your regular service provider, and it shows you what it costs you to go to a hospital, what it costs you to go to a mental health service provider, and what it costs you to go to an inpatient similar to hospital. All of those should be in parity. Okay, so when you get these documents, that's what you want to look for. Your summary plan description, you can get from your employer, download it from the intranet, or ask your HR, and have those documents, because that is the how the plans make the benefit determination. It's based on the plan rules, which are written in the plan documents. And Karen mentioned earlier about autism. We had another case where a whole plan excluded treatment for autism. And with our agency's investigation, we were able to result in that plan revising their terms to cover the benefit. And they ended up having to reprocess over 1,100 claims, totaling $631,000. So we're making an effect on the plans and forcing them to be in parity, essentially, because that's what the law says, and that's our work. So when you have denials of your benefit, make sure that you get information, because the plan is required to provide you information, a reason for the denial. You were out of network, it wasn't a covered benefit, or you didn't get pre-approval. Those are things, or it could be any other reason, really. Those are reasons that have to be listed on your denial. Now, first thing you do when you get a denial, don't panic. Unfortunately, it's kind of common. What you should do is know that you have the right under the federal law to file an appeal. And that's the first thing you should do. File an appeal, because the appeals are time sensitive. So you don't want to wait, don't want to sit around and think about it, put it off until next month. It's time sensitive. And it's important too, because if the plan denies your benefit, that means that you're not getting the benefit. So it could prevent you from getting more treatment. So you want to take care of that as quickly as possible. And file your appeal. You can call your plan to get more information. You can file, if your plan allows it, there may be an option for an external appeal. And then you can always call our office. But our agency does not have a role in the appeals process. So we don't make a benefit determination. And we don't have a role in the appeal. So we cannot look at a plan, a benefit that's denied, and demand that any insurance carrier pay that benefit, because we just don't have that authority. But what we can do is get the plan rules. We can review that. We can review that with the employer, the plan administrator that is installed at the company that you work for. And we can review that. They have the authority over the plan. They can look at that with the insurance carrier, and together we can figure out if the plan, incorrectly denied your benefit, then they have to correct it and pay the benefit. Okay, so you can always come to our agency for help, come to EPSA for help. This is our toll-free line. We're in Pasadena, by the way. Our office it covers the southern half of California, Arizona, Hawaii, and the Pacific Islands. As a federal agency, though, we can help anyone around the country, because everything we do is related to a federal law. You can call this toll-free number at any time. It goes in, if we're not open when you call, it creates a message and we can call you back. You can always submit a question on our website at askebsa.dol.gov. And we can get back to you. Our service to the community, being that we're a federal agency, we can help anyone without charge. We can help everyone with about 100 different languages. So feel free to contact us if you figure that we can help you. Even if we don't help you, if you don't have a denied claim, we can give you information about what your rights are, so that you can maybe prevent having a claim that's denied. So feel free to contact us. So we have publications on our website. You can see here we've got several publications on mental health, Parity, and there are many, many videos too, little short videos about your rights and information on the publications. You can go to our website to get that. And if you want, you can always subscribe to get email updates. Get the newsletter from Department of Labor. When you get the newsletter, it's agency-wide. I mean, it's DOL-wide. So you might get information about other DOL agencies like the Wage and Hour Division or OSHA. But if there are announcements, kind of like what Karen was saying, how the law is changing, there may be announcements in these updates. So if you're interested, you're more than welcome to do that on our website. And that is it for me.
I think this has been awesome. Honestly, this is my bread and butter. I know it's kind of strange when somebody says they like wonky topics, but this is both really important because I find it important and interesting, but also because we get a significant portion of our callers who, if we knew this stuff, they would be far better off. I have sent people your way, Thuy, but I don't know if they ever actually got in contact with your office. Karen, now that we know about your slides, we will proliferate. We'll send them all out. I actually didn't have this as a part of the event, but I was wondering if either of you have questions for the other one that would help us better understand how the two of you might be able to work together. Because I know Karen said you work with families, but I don't actually really know what that means. So maybe it's a question for both of you, or it's a question for you, Karen, because that's actually it wasn't in the slides. So I'm just curious how y'all work, how you work, Karen. Oh, you're still muted.
Referrals from educational consultants and from facilities and from message boards. People find me on message boards, and then also people just find our website. But so they can just call. We answer questions. We'll do a good intake and see if they need our services. But what we mainly do is we can call in and get authorization for families. We would work with the facility and make sure that they're okay with us doing that. And we would call on their behalf and get authorizations. And then people come to us afterwards and they have been denied. And so we'll look at their denials and we'll look at their plan manual and we'll write an appeal. We'll get their medical records. We'll read through the medical records and we'll write a very detailed appeal. And I recently reached out to Thuy's organization because we had this client that had gone through all the processes and done everything right. He had another advocacy organization that was working with him. And the company kept blowing it off. Like they didn't respond to him in time. And then they eventually denied him because they said he didn't file timely. But we had proof that they had our documents, that they had everything, and that we had proof that they called and were like, when are you going to send the denial letter? And so we never got a denial letter. So there were all these ERISA violations, and we sent it on to Thuy's program. It was a huge file, and I don't know that they were really happy to get it because it was a lot of work, reading through the documents. But I hope we get a good result. And we've sent other cases, like I think we had an autism client. Actually, maybe that was a state thing. But we've done a few other things. Oh, we have these cases where they tried to go to a mental health facility that was out of network. And the plan came back and said, no, your facility doesn't provide 24-hour nursing care. And so we're not recognizing this as a legitimate facility. And so I looked at the requirements of like skilled nursing and I think hospice care and some other intermediate level medical programs that didn't have that requirement of 24-hour nursing care. And so we got them. The Department of Labor they told me that they've sent it to their enforcement team. And I think, I'm not sure, do you want to say what that means? Do you know, Thuy, when they send it to enforcement? That's what we've been told. And so we're optimistic.
That'd be too big trouble if our enforcement office gets involved.
Okay. So
here's what I do. I help people who call in or send us a letter or submit something on our website. And it's usually either for themselves or for a child. Okay. And like I mentioned, I try to work with the employer to get documents, to have a review, and to determine if the plan is in parity or if there's any violation. If they refuse, sometimes we have to get our enforcement office involved, or if we determine that it's plan-wide. For example, like my example of the not covering autism treatment, that's a plan-wide matter, and our enforcement office gets involved. But yeah, you don't want to hear that word.
Yeah, whenever I think of federal government and enforcement offices, that doesn't sound like it would end well. I think the best.
I hope it doesn't.
Yeah.
They're not friendly like me.
No, I imagine not. I imagine not. So I have a question, and I'm gonna see if other people have questions, and other people have questions. I'll keep asking questions. I have a lot there. But okay, so this is the question about appeals and other things. What is a common error people make that can it could derail the whole process? What's that common error?
The most common thing that I see is not providing enough information. Because if sometimes the benefits are provided. For example, let me give you a medical example. If your plan covers knee surgery, okay, but if your doctor says it's medically necessary for you to get knee surgery, and doctor goes to immediately to knee surgery, you can understand that generally that's not going to be covered because the plan will expect you to maybe try a brace or a cane or, physical therapy. So they're going to deny that as not medically necessary because you didn't try these other things, okay? But if you did, if the doctor had you on a treatment, you had the cane, you had the physical therapy, and now the only other option is to have the knee surgery. And they go to knee surgery, but they deny it because they say, well, we don't see that you did anything else because they didn't submit all of the information leading up to that.
Like how I wanted.
Similar to mental health, there's a lot of information that's generally not provided either all at one time or even when it's requested. Sometimes the insurance requests it from the participant who doesn't have all the records, and they assume that the doctor is going to submit it. So, there's a lot of missing links, but I think that's the most common thing that I see.
We have to be conscientious of time. So, Karen, what's a common error you come across that can derail the process that would be a lot of time saver for your clients? Oh, you're still muted, Karen.
If they didn't get pre-authorization and it's a hard, fast requirement for residential treatment, which it often is. So if they fail to get that at the beginning, and there's nothing in the manual that says something like, we'll penalize you $500, which some of the plans do that. They say there's a $500 penalty for failing to get pre-authorization. And then it's like, okay, you pay the penalty and then we're still there. But if it's a flat out written in the manual like that, then, we're kind of stuck. We don't really have a lot of ground to work with.
Okay. Well,
that's an example.
Everyone who's come, if you need to get in contact with either Karen or Thuy, you can see they're very friendly. They know a lot. Thuy has an enforcement office. So if you ever need some serious federal government letters showing up on your behalf, I know we get, it's there. So, Karen, Thuy, thank you so much.
Thank you.
And if any of you have questions, and you want to get directly in contact with Karen, just email me, and then I will send Karen's email to you. Karen, is that okay?
Yeah.
Excellent. And then if any of you need the federal government stuff, what I'll do is I will email those forms from Thuy's office to you, cut out the middleman. I then become the middleman. So,
toll-free number here and
excellent.
How you can submit a request on our website.
Great. And Karen, if you will share your slides, I know I've had a few people ask for them. So anyone who is here tonight, you will definitely get her slides. I'll be emailing
them
out
to you tomorrow.
Perfect. Thank you.